Well, good afternoon, everyone, or wherever you are across the globe. Great to be with you for the 73rd edition of SADS Live. So, I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic and director of its Winland Smith Rice Genetic Heart Rhythm Clinic and the Sudden Death Genomics Laboratory. Today, I'm here on behalf of Alice Laura, our CEO of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation, where I've had the privilege to serve as the president of its board for many years now. And we've been together almost every Friday since February, March of 2020. And so it's so good to get to be with you as we've shifted to every other Friday or at least 2 Fridays a month the last month or so, rather than doing it every single Friday. So today I'm with you from Traverse City, Michigan. And I'm really excited to get to be here. It's a special weekend for my wife and I. Right after this, I'm heading to a very special patient and her mom and dad, where we've become dear friends over the last 23 years of caring for her. Some of you may remember Stephanie and Stephanie's story. I don't know if it's available through internet searching, but if you looked up Doctor's Prom Promise, you would get the story of when I surprised her and took her to her prom, now some 12 years ago, 10 years after her heart transplant. So tonight we get to go celebrate life with Stephanie and her husband and her mom and dad. And then tomorrow we head up to Mackinac Island in Michigan. I've never been there before, but there I have another incredibly special patient, Chase, and his mom and dad, where over the years, my wife and I have become close friends with his mom and dad, and going to spend a special day together celebrating life with them. And so many of you are coming on in, and I see Michelle, hello, greetings, and Kelsey, and Guten Tag for Erica in Germany. Many of you are patients, families, supporters of the SADS Foundation, special families with SADS where you have a close relationship with your healthcare team, some of you with our healthcare team at Mayo Clinic, and to see a patient-physician relationship eventually transcend to a dear friendship. It's really special. And today is going to be a special day for our next 40 minutes together, 45 minutes, 40 minutes, yes, as we take your questions. And I'll do my best to answer them. And as we'll see questions come on in, I'll grab them. I won't pick them to try to see which ones I know the answer to. I'll take them in order. So no cheating. I haven't seen any of them ahead of time. But before I do, reminder about all things COVID. Worldwide, we're approaching 231 million cases. We've had 4.7 million deaths globally. In the United States, of those cases, 42.7 million are in the United States, and we're approaching 685,000 deaths. So get the vaccine, the jab, as some people call it. I'm vaccinated. I got Pfizer, others have gotten Moderna and the J&J. And guess what? Newsflash, my fourth child, well, second son, second oldest, but the holdout, texted me the other day and said, "Hey, Dad, I've gotten the vaccine." So the entire Ackerman family, after he gets his second dose, will be vaccinated. And we thankfully have made it through the pandemic infection-free and now soon to be fully vaccinated. You are seeing about the booster shots, and recently the CDC in the United States said that boosters, a third shot, is appropriate for those 65 and older or those with immunocompromised situations. And then we actually had the CDC director, I think just yesterday, override the panel's recommendation and also supported the booster shot for healthcare workers, teachers, and the like. So do your part. Get vaccinated. I have zero concern. We've had 6 billion doses of vaccines administered globally. If people are talking about, I'm not sure about its safety profile, you ought to be sure by now. Every drug, every vaccine has potential for side effects and adverse reactions, but boy, after 6 billion plus doses, the safety profile overall is really, really impressive. We're wrapping up SADS Safe School Month. We had some really good programs, and we'll be coming upon next month Sudden Cardiac Arrest, or SCA, Awareness Month. And so I think you're going to like what we have on tap for next month. And I didn't see it, but I was told that 2 nights ago on Wednesday on Fox, so shout out to that network, there was a show called Resident. I don't know about that show, anything about it, but one of the patients or people who presented to the emergency department had Brugada syndrome. And so if you have Brugada syndrome and you want to reach out to your local news network and maybe put a link to that show or that episode from The Resident and tell your story, your Brugada story, that would be great. Well, here we go. We are at 34 minutes on the counter, and I got to scroll up the list because many of you have joined. Hey, Toby from Austria. Glad you could join us. And I'm going to look for the first question. Oh, and I like the SADS recommendation. Keep them short and easy to read for me. And there's Alice joining me. Well, hello to our CEO. So maybe Aaron's going to remove Alice because Alice, again, has her microphone but off. She was muted. But keep them, word of the day, pithy, so that I can glance over and grab those questions. And the first one that I'm seeing and that I'm taking right here, I'm getting it, is, I'm looking forward to meeting Eugene. So Michelle is asking about any correlation with cognitive learning difficulty and long QT syndrome. Could the multiple events, faint seizures, and so forth prior to the diagnosis have caused any anoxic, lack of oxygen, brain injury, contributing to those learning difficulties? And so, Michelle, I thank you for the question for your son. And I think the short answer is there's no evidence in our long QT syndrome patients, if we look at all long QT syndrome, of a tendency towards learning difficulties or cognitive IQ impairment or anything like that. So overall, we won't be able to use long QT syndrome as an excuse for getting a B grade when they're fully capable of getting an A. Now, having said that, what you did point out was, could there be an insult from a long QT triggered event or a CPVT or a Brugada, any event where there's a dangerous arrhythmia that made you faint and it's gone on longer to where now the brain has been deprived some level of oxygen for a while. And of course, we know the longer the person is down before resuscitation, if it's going all the way to sudden cardiac arrest and nearing sudden cardiac death, if electricity hasn't gotten to them and effective chest compressions haven't been provided and they've been down 5, 10, 15, 20 minutes, then yes, there is what people have called the post-cardiac arrest fog, and where there are and can be some consequences of the anoxic or the hypoxic injury. But the disease itself, long QT syndrome, not associated with cognitive or learning difficulty. And that is in contrast to a disease, CPVT, catecholaminergic polymorphic ventricular tachycardia, where in CPVT, just published a paper recently in the last year. We were on it, led by Arthur Wilde in Amsterdam and his team, showing a measurable degree of learning disability in CPVT in about 10%. So there may be something, and that seems to be unrelated to being symptomatic or asymptomatic from the disease, the heart rhythm abnormality itself. There may be something about a ryanodine receptor mutation in the brain that could be contributing to some level of learning disability, autism spectrum challenges there. The next question, great question, Michelle, and I hope you and your family are doing well, is we speaking of CPVT, they're asking about what about exercise and CPVT, and we addressed the topic of exercise where for a long time the word on the street was if in doubt kick them out, and that if you had a genetic heart condition of any flavor, long QT, CPVT, hypertrophic cardiomyopathy, doesn't matter, you're disqualified. And as you know, our program at Mayo Clinic really challenged that thinking in 2000 when I joined the faculty. And I said, why are we doing it this way? Why can't we do what we do in so much of medicine, shared decision making? And with that philosophy in place, we started helping and enabling and supporting athletes with a wide variety of genetic heart conditions return to play. It's a really good paper, I must say, that we published earlier this summer in the Journal of the American College of Cardiology. You should check it out. It looked at our 20-year experience of over 700 athletes now under my watch, where we've enabled, supported their return to play, and the results have been great. Not zero deaths, but not zero episodes or zero events. And in those athletes, among those athletes, do include CPVT. We did publish our CPVT experience several years ago now, and now we've extended that with them. And so the event rate of on the field fainting or needing and having a defibrillator rescue, not external, but those who had an ICD go off higher than long QT. But we're talking about an event rate among my CPVT athletes of about a 5% chance per year for a non-lethal event rate. So I have athletes with CPVT who have gone all the way now from little league to varsity level to university, and I even have a professional athlete with CPVT. Next on the docket is Wendy's. Thanks, Wendy, for your question. Is 20 milligrams of propranolol good enough for an asymptomatic long QT patient? Should it be upped? And Wendy, I love the question, and it really is a chance to say it is not a one-size-fits-all remedy or treatment plan for any patient with any of our genetic heart conditions. Do I like propranolol for long QT syndrome? I do. I like that as one of the beta blockers. I like two of them, it and Nadolol. Is 20 milligrams enough? It depends. Are we talking about a baby, a child, or a 60-kilo adult? A 60-kilo adult, pretty wimpy dose. So we have to tailor the dose to the person, to the risk meter that we're assessing, so that we provide appropriate countermeasure. And then even we have the question in asymptomatic long QT syndrome of do we even need beta blocker therapy? That's newer. It is a bit edgy, if you will, but we just recently published our initial experience of what we've called INT, intentional non-therapy, where we know it's there, it being the long QT mutation, but we are intentionally choosing not to treat it with beta blocker or denervation or a defibrillator. We're just implementing the overarching QT-related preventative measures. And I don't mean just as in trivial, because those preventative measures are life-saving. So great question, lots of things to unpack, and I hope we started to do that. Farron, love the spelling of your name. I love the name. Is there such a thing as a person becoming immune to beta blockers? Good question. No, technically not in terms of where there's immunity developing such that the immune system neutralizes what the beta blocker does. Remember, a beta blocker puts a barrier around the heart or around the flammable fuel, whether that fuel is long QT fuel or CPVT, and it makes it harder for the sparks of life, adrenaline, fight, flight, fright, to reach the fuel to cause the long QT explosion, the danger rhythm. So beta blockers block the beta receptors that line the heart muscle. And there's no immunity that develops. I think what you could be getting at is, if somebody has a breakthrough event, they're taking their beta blockers and they're taking them that actually turns out to be the number one reason why the beta blockers didn't work, is because the person said, oh, whoops, I kind of stopped taking my medicine 4 days ago. So it's hard for them to work when you're not taking them. Now, let's say you are taking them faithfully and you still had a long QT, what we call a breakthrough episode. We use the term breakthrough because it broke through the treatment. And then we have to ask why. Maybe we didn't have the dose high enough, or maybe the disease is just more stubborn and irritable than what the protective effect of the beta blocker can provide. So we have to try to figure out the why did the person still have an episode despite being on the beta blocker, or what beta blocker were they on? Remember, if they were on the one that I dislike a lot, hate, atenolol with an A, then I wouldn't call that immune or a breakthrough. I would call the person having a long QT episode when they weren't really on very good therapy to begin with. Good. Erica. Oh, hi, Erica. I've had a question from you in the past. Is there, I got to get going, don't I? There are lots have come on in. I'll take these and I watch the counter. I love question and answer session. Is there experience with using the life vest where the wearable defibrillator is an AED not advised yet? Might be helpful in a stressful situation. Oh, that's a good one. So the life vest, so you all know that for children with the genetic heart conditions, I like and I recommend the automatic external defibrillator, the AED, as safety gear. And it's really Boy Scout be prepared, Girl Scout be prepared recommendation, not out of an anticipation of needing it. We have used an AED to rescue a treated child of mine 4 times in 4 children out of 700 treated children in 20 years. So almost never will be necessary. But I like it as the idea of a safety gear, fire extinguisher light. Now, the life vest is a wearable defibrillator, and I like it. We don't use it that much, but there's been a couple situations, Erica, where I've liked it a lot. And so one, for example, is the person just had cardiac arrest and they're not ready for an internal defibrillator yet, mentally, psychologically, or there may be a chance once we've made the correct diagnosis to come up with a non-defibrillator treatment strategy, even though they started with the full deal of cardiac arrest. Well, putting on the life vest, getting them to a center of excellence, doing the methodical, meticulous evaluation might be a scenario where the life vest has a great use, and we've used it for that purpose. Another situation where we've used it, not very often, is in an LQT2 woman, pregnant, now postpartum, where we know their risk window is higher than what it was before pregnancy or during pregnancy. Might we add the life vest for a window of time until we get through that postpartum phase, and or until we adjust the medicines? So there's some examples, but honestly, Eric, I think we probably have used the life vest maybe 10 times in 10 people in my entire practice these last, I can't say 20 years because we really have had the life vest the last 10 years or so. But there are times where I have and I like the life vest. Paul is sharing, can the long QT interval vary from year to year? Can it get worse when you're 10 years old compared to being 2? We look at that. Part of the reason we check to see what is your yearly QTC or your every other year when you come in for your yearly evaluation is we're learning that where your QTC hovers on that snapshot, that morning ECG, might provide us more risk information than basing your risk based upon just one value. So, for example, for a long time now, a paper published over a decade ago from the Arthur Moss, the late Dr. Arthur Moss registry, suggested that we, the physician, should go by the person's maximum QTC ever recorded on their 12-lead ECG, whether that was a recording from 10 years ago or a recording from yesterday's ECG, that one should slot them in and designate them as to their risk. And we have a paper coming out soon to show maybe a better readout is kind of a composite or a median or average of all of those yearly QTC numbers. And we know that if the QTC has stayed below certain thresholds every single year, the risk is super low, for example. So, yes, there's some swing in the QTC number. We look for what kind of swing there might be, especially in young girls transitioning into and through puberty, so we can see what kind of effect estrogen and progesterone might be having on the QTC. We do that in the males to see what kind of QT shortening effect might be happening as testosterone arrives. So we do monitor it. We're learning that there's risk value in knowing what has that QTC done over the years. And so I love your question. Thanks. Christine's, oh, this is a good one. Is there a connection between CPVT and anxiety? Your 14-year-old has always been on the anxious side. Could they be related? I don't think they're directly related. I like the question, but I don't think there's something about the fundamental genetic mutation in CPVT, the ryanodine receptor, or long QT syndrome or Brugada syndrome that affects the neuronal circuitry in terms of the chemical imbalance theories and so forth of anxiety. But there's no doubt that the disease and a person's journey with his or her disease can be very anxiety provoking. That the device therapy, well intentioned as a defibrillator may be and is, if there's been any device related malfunction, inappropriate shocks, we definitely have an anxiety producing situation, PTSD, that can come from the inappropriate shocks. Knowing that you have a genetic heart condition that could culminate in sudden death is anxiety provoking for some individuals. And so it is interwoven in some levels, but I don't think that the genetics of the disease has a crossover to contributing directly to an anxiety predisposition, for example. Naomi's question, no, it's a little long, Naomi. What is your best advice for somebody gene type 1, so I'm assuming LQT1, no symptoms, that's great, or events, who cannot tolerate any beta blockers, not eligible in the UK for sympathectomy, denervation surgery, or an ICD, but I'm uncomfortable being untreated when my job is a fitness instructor? Really good question, Naomi. And this one to unpack is a little hard because for me to sort of endorse the INT, the intentional non-therapy that we spoke of a little bit ago, I would want to know and need to know several things about your LQT1, the specific mutation, what is your ECG, what does your QTC look like at rest, and what does it look like during the stress test? How easily is it to make the diagnosis or see the electrical glitch? But let's say you cannot tolerate any beta blockers. Well, before we conclude that, we might need to look at how was it attempted. So I've seen so many patients, Naomi, where they couldn't tolerate the beta blocker, and then we learned the why, and that is they were 20, 30 years old, athlete, never seen a beta blocker before, and bam, they got put on 40, 60, 80 milligrams of Nadolol. Well, no wonder they didn't tolerate the medicine. We didn't give you a chance to acclimate to it. And so when you are super low risk, as it looks like from your description, there's no need to start on a stiff dose. So if they didn't do it the right way, maybe we didn't give it a fair chance. And the fair chance would be to start you on a whiff of Nadolol, for example. As by whiff, I mean 10 milligrams, a half of a tablet of the smallest size tablet. Stay on that dose for weeks and then gradually go to a full tablet. Stay on that dose for weeks. And so slowly work towards a goal dose. And if it didn't work with Nadolol, we could try the same thing with propranolol. And the last medicine that I would try for beta blocker is carvedilol, a little bit newer in terms of its use in long QT, but it's another one that I'd be willing to try before concluding that the person was not tolerating their beta blocker. But if you truly weren't tolerating beta blocker therapy, then we would really have to be deciding, do we just go with prevention only, drugs to avoid, electrolytes to replace, fever to reduce, fish oil to take if you want to, and not take any medicine? Or do we try to like get you over to a place like ours here at Mayo Clinic for left cardiac sympathetic denervation solo therapy? And solo therapy with denervation for certain LQT1 patients is a great, great treatment option. On Eva, due for the booster. Question. Okay, good one. Is it true that progesterone-only contraceptive pills are not advised for long QT syndrome? At the moment, I get treated for endometriosis, and the doctors aren't sure of that. Well, we are learning a lot about the sex hormones, estrogen and progesterone and testosterone, and their effect on the heart's electrical charging system, the recharging system, which is reflected by the QT interval. And it's been known that testosterone seems to be QT shortening. There's been confusion and not clarity yet on for estrogen and progesterone, which of those are QT prolonging, which of those might be QT shortening. We published a paper back in 2012 raising a concern about one of the contraceptives, and that was the injectable, the Depo-Provera, that I think lasts 3 months. And with that one, we saw a few examples of women on Depo-Provera, LQT2 women, that were clearly having triggered events, that we removed it, they went silent again several months later, put it back. So I think there's a connection. And then more recently, the Long QT Registry out of New York just published some updated experience about the sex hormones in women with long QT syndrome. And again, a signal that the progesterone containing only might be QT triggering, QT irritating in women, again, particularly those women with LQT2. We're actually trying to, they have an American Heart Association grant to look into that closer. And together we've merged the New York group, our group, and Arthur Wilda's to look more closely at exactly and try to dissect exactly what is it about the pill, which components, the estradiol component, the synthetic progestin component, as being the one that would cause a tendency for prolonging the QT interval. And Toby's 14-year-old daughter got her Pfizer. Yay, good job on that end. And any special recommendation for CPVT patients for the days after the shot or the jab? Not at all. They'll navigate it just fine. She'll recover just fine, especially after the first one. Almost never even a fever. And we don't even really know that fever is irritating in CPVT like we know fever can be in Brugada syndrome. And so I don't think you need to do much of anything for that. There's a tendency after the second shot to be more ill for 24 hours or under the weather or achy from the second shot. And so my view is if they were ill under the weather after the second shot, feeling febrile, just to make you feel more comfortable, I would lower it. And Kayla's, what are your thoughts on individuals with CPVT or other SADS conditions using alcohol or marijuana where it's legal? Good question, Kayla. So a couple things on the alcohol story. We really only know that alcohol past buzz, so alcohol to drunk, is probably Brugada dangerous. We don't know, it may be long QT dangerous in that if you have too much alcohol consumption, you can get relatively dehydrated. If there's dehydration and changes in your electrolytes, then that could be QT irritating. There's really no good evidence to suggest that that same cascade might happen for somebody with CPVT. But as a general rule, I think alcohol to drunk does no one good ever, period. Hard stop. So I would discourage that. I think a recreational alcohol glass of wine at your Italian dinner or whatever, no concern from that standpoint. Marijuana, there's no evidence that marijuana is CPVT irritating. I think in the future we're going to learn that it was a mistake to legalize marijuana. That's just my thought. I think there to suggest that it is heart organ neutral. I don't buy that. Lung organ neutral. I don't buy that. So I think I'm not a big fan of marijuana, even where it's legal. But could I discourage its use out of CPVT fear? No, I can't. Brugada, on the other hand, yes, I think there's some pretty good evidence that marijuana could well be Brugada dangerous. So for the Brugada families out there, we say don't get drunk on alcohol, nothing past a buzz, don't inhale, and don't do cocaine. So we take those three things away from the Brugada person. Joyce is asking for a 12-year-old son with LQT2. How do you feel about continuing in competitive sports? The QTC in recovery is 590. So that number, Joyce, the recovery phase QTC doesn't bother me at all. We have not shown that what the QTC does in the recovery phase is risk predictive. So what we really use to gauge and assign some level of risk forecast is what is the QTC at rest. So he clearly has ECG manifest long QT syndrome without even knowing his resting ECG. He is LQT2. He's pre-pubertal, peri-pubertal, so he's still in an at-risk window. Can he compete in sports? My view, depends. Depends on him and his mom and dad. Are we going to be 3 for 3 in agreement? Depends on what I think about his treatment program. Do I like it? So bottom line, if the athlete, your son and mom and dad are all in agreement and I like the treatment configuration and I feel good about his protection, he would absolutely join the other 700 athletes of mine who have been returned to their sport of choice. And again, to date, a very satisfying result for 20 years now of overall in long QT syndrome, about a 1 to 2% non-lethal event rate among my treated patients. Carmen's asking, is exercise acquired long QT as dangerous as congenital? Suggested treatment protocol. Oh, that's a good one, Carmen. So what Carmen's getting at is, I don't know, not a new phenomenon. It's a newly appreciated one, really dissected by a dear friend of mine, Peter Schwartz, and his research team out of Italy. And this idea about exercise acquired QT prolongation is the suggestion that certain training programs can cause a remodeling effect on the heart's recharging system, pushing their QT intervals to the right, making them longer than normal range, making them look potentially like long QT syndrome, where in Peter's program, they've deconditioned some of these athletes and show that the QT interval normalized or returned back to its normal distribution. And we actually had seen this. We weren't as smart as Peter's team to put 2 and 2 together, but we had seen this where so many of our patients who we saw that we ultimately removed the diagnosis of long QT syndrome were athletes flagged as part of a screening program, and then the due diligence was they're shut down. They eventually saw us 3 to 6 months later after being inactive. Their genetic test is negative, and when we now see them 6 months later after being sidelined, their QT was looking way better than what flagged them on their pre-sport screening ECG. So we kind of were there. We just didn't put it all together. But to your question, Carmen, I don't think it's very dangerous at all. I think this is largely uh, uh, cosmetic in terms of what the exercise program is doing to the QT interval. And for me, somebody where we've concluded that they have a training effect going on their QT interval. We've ruled out long QT syndrome genetically with a negative genetic test. My treatment protocol for them is largely just countermeasures, meaning maybe it's not a great place or a great scenario to add QT drugs to the mix and the other preventative measures. I don't necessarily, and I have not typically placed them on beta blocker therapy. And we are at 156. Let me see if I have, oops, I almost, I'll do a couple fast ones. Asymptomatic Brugada syndrome. Can I use a hot tub? Emily, I like hot tubs. And yes, you may. Some people would say don't be in there for too long. Don't have it set above 104 degrees Fahrenheit. And what's that? Is that 40 Celsius? I think. I have mine set at 104. And then don't bake in it for more than 20, 30 minutes. If you're in it 20 minutes or less, hard to increase your core temperature. And then it looked like my computer jumped past a few. Sorry about that. I was going to take them all. I'll take Paula's as the last one, or actually Joe's, and then Paula. So Paula's question, I don't like atenolol. My son's being treated on this. Can I ask you why you don't like it? It takes a while, but I would just say if you look at the largest centers taking care of long QT families throughout the world, I'm not sure you'll find what I would call a center of excellence using atenolol. We raised a concern about it years ago now, almost 20 years ago. We and others think that there's something more therapeutic, more protective with the so-called non-selective beta blockers, nadolol, propranolol, maybe carvedilol, than the beta-1 selective beta blockers of atenolol and metoprolol. And there's some thoughts about the non-selective nature of those other beta blockers, where they also block not only beta receptors, but alpha receptors, which atenolol does not, as to why the other beta blockers, propranolol and nadolol, may be superior to atenolol. I think they definitely are, but we will never be able to do a randomized study randomizing patients with the same risk of long QT episodes and give one group atenolol and the other nadolol and determine which half has less events. And the reason it'll never happen is you will never get the long QT centers of excellence to do that randomized study, because we're already totally convinced from experience over decades that nadolol and propranolol are simply better beta blockers than atenolol or metoprolol. And last, Joe, we will take your question as one of the first questions. I'll have my boss, if she'll let me. I do everything that Alice Laura tells us to do. So about yours, and Joe's is, do beta blockers affect weight in adolescents the same as adults? And this whole issue about beta blocker side effects, what are those side effects? Do those side effects include weight gain or a difficulty to lose weight, are really important ones for us to tackle. I'll give you the teaser. Yes, beta blockers can impact weight and make it difficult to lose weight. And I do think we need to add some scientific evidence to that statement, but I'm pretty convinced it is more challenging to lose weight when a person's on a high dose of beta blocker. Now, I see we've given some information about the resident. So, and the SADS Foundation checked on those. We are going to be back. Usually, we now have gone every other week, but we will be back next Friday, the first Friday of October. We wanted to launch Sudden Cardiac Arrest Awareness Month by being with you on the very first Friday of the month, which happens to be the very first day of October. So I hope you will join us next week. We might need to pick up with your questions because you've given me so many great ones that I didn't quite get to. I thought I was on task. So I love your questions. Thanks for them. They are phenomenal questions as always. Until we're together again next week, I wish you well. And I would encourage you as we wrap up SADS Safe School Month that you might take a moment if you benefited during our times together, these 73 episodes of SADS Live. Go to our website, www.sads.org, or if you like the other one better, www.stopsads.org. It'll bring you to the same place. Top right corner says donate now, and you can partner with us for your end of the month giving and your way of saying, keep it up, SADS Foundation. We are benefiting from what you do, and we would like to partner with you to help what we do at the SADS Foundation do it better. So join us in that way if you can, or ask a friend if they'll join us in that way for you. So until next week, have a wonderful weekend. And I'm off now to go see Stephanie. And like many of you, she's one of my favorites. I have lots of favorites, but Stephanie is a real special one. So check out the story, Doctor's Prom Promise, if you want to, and then you'll see just why Stephanie is such a beautiful person. Blessings to you all. Take care, and I'll be back with you next Friday.